this is part of an initiative that was funded by the Peter Salovey Foundation, where we're, through cooperation between the Department of Philosophy and the faculties of medicine and nursing and midwifery, we're creating space for dialogue between medics and philosophers, because we're already asking a lot of the same questions about life and death and what is good evidence and what is autonomous decision making and so on. And so we should take this opportunity to turn off all beeping devices, because we're making a recording of this that we're going to put on the web page. So our first speaker, David Beard, is Professor of Musculoskeletal Sciences at the University of Oxford. Among many things, he's an alumnus of King's at the School of Biomedical Sciences. Master's of Biomedical Science.
Yeah, that's great.
Yes. So welcome back.
Thank you.
We're proud of everything he's done in the meantime. I'm not going to go through details, but among other things, he's co-director of the Royal College of Surgeons Surgical Intervention Trials Unit. And so a lot of his work focuses on the design of surgical clinical trials, especially in orthopedic healthcare, and including questions about placebo-control. Yeah, so maybe we'll just get to it and let you
get started.
Yes.
Not a bad idea as well. So, thank you very much for inviting me, and it is really wonderful to be back here. It's 6:30. It's a lecture at night, so I know what those are like, and so it's going to be relatively light. There's going to be some stuff to think about, of course, but I'm not going to give you lots of detailed information. It's going to be a walk through a particular topic, and we're going to talk about placebo-controlled trials in surgery. As has been correctly said by Sherry, I'm a co-director of one of the Royal College of Surgeons surgical trials units, and I'll talk to you a little bit about that later on. As it's very topical at the moment in terms of rugby, I live my time in Wales. I actually have a home in Wales. I actually derive from the Isle of Man. I'm a Manxman. I actually also have an Australian passport, so in that group it's an absolute nightmare for me. I don't know who to support. Now, I don't know what you were doing in 1991, but these things happen. Talking of rugby, Australia beat England actually in the rugby there at that time. The Birmingham Six were released. That gentleman there died, you may recognise him, Robert Maxwell, and after a complicated web, and Freddie Mercury also left the planet as well at that time. Now, on that time though, I was probably in this lecture theatre, I don't know whether it was or not, and it was in 1991 that I undertook a course here at KCL as a young clinician scientist who was very frustrated with what he was doing, and ended up on an MSc, which was very, very formative for me. And one of the most important lectures of that series at that time was one of History and Philosophy of Science. And a relatively young lecturer who had just come to the department gave us those lectures, and he's here today. I was absolutely delighted that he was going to be here, because I haven't seen him since at all. And it must have been very difficult for you in those days, because there was a group of technologists and technicians and rote learning scientists who had to have that broken down and think in a different way. And that has happened to me, and I look back on those lectures now, and if you are involved in medicine and science, I would say those sorts of modules and lectures are absolutely critical. For me now, what I learned about philosophy underpins now my scientific thought, and I go about it in a totally different way. No recipes, left field thinking, and underpinning it from very interesting principles. And I'm very grateful. So, just so that if you are able to get lost in your way and think, what am I learning this for, why should I do it, it's very, very important. And you do see the scientists who've gone through that process. Okay, in terms of outline of our plan, what we're going to talk about today, I'm going to go through these things. The need for surgical trials, just in general. We're going to talk about designs and comparators a little bit. We're going to talk about placebo, which is one particular design, very interesting for me and hopefully for you. There's some issues with that, and we're going to go through that. And then interpretation and changing practice. If you want to shout out at any stage, I'd rather it be interactive than sit there and just go to sleep. So if there's things that are there, topical, pop your hand up, say, and we'll talk about it then and then. Hopefully we won't run out of time. How long have we got, Sherry? I'll put it in. About a while. Okay, we'll get. Let's start with the need for surgical trials then. Now, that's a large figure. 235 million operations performed per year worldwide. And there is some sort of romance about surgery. I don't know what it is, but people love it or they hate it. But it has a peculiar draw to it. And it's quite expensive. So in the NHS, 40% of the NHS budget is spent on surgical-related care, which is very sizable, as you can see. Now, one of the problems is that's not reflected in the research that's spent on surgical care, and only 2% of the NIHR, which is the research side of the NHS budget, is spent on surgical-related research. That is an incredible imbalance. You've got 40% of care and only 2% on the research. So that has to change. Why are we in this situation? Why is it like that? Well, surgery is a very odd discipline in some ways, and it's come through a different route. Pharma and pharmacological interventions have been evaluated in a very different way, and the approach has been different from the start. It's well established. It sort of hails from the days of some charlatans often selling things which have no proof of evidence at all. And eventually the physicians said, we don't want this anymore, we want a third party to regulate this and to say what we can use or not. And the FDA, the Federal Drug Administration, came into being. And they control in the States, and we've got the equivalents in Europe, what medicines can be used and what can't, and they only come onto the market if they actually have some proof of efficacy. Which is the right thing, it's a good thing. Surgery is not like that. Surgery is very different. And that's a real shame. And you'll see in a second maybe why that is. And that's a rather damning statistic that less than 1% of surgical patients are recruited into any trial to try and help with the evaluation of some of these interventions. And something which seems so important, you would be forgiven for thinking that we'd have evaluated this really well, but we haven't done. People have got hold of this. You may know that name, Richard Horton, the editor of the Lancet and BMJ, involved in the BMJ at the time. Surgical research, he had that headline and it crucified the surgeons. I've got very good friends as surgeons and I'm very supportive of them. And this was a very testing statement. Surgical research or comic opera, questions but few answers, and that headline on the Lancet, which stirred people into action. So in some ways it was a silver lining. But these sorts of headlines are not so good. Common surgical treatments, half as likely as medical ones to be based on RCT evidence. So it's a problem. It's a problem because other parts of our world, of our community, have embraced things which perhaps you'd have expected in something so invasive as surgery where you're dealing with people's lives. You can go to a cafe, you can go to your cafe here, and they will adhere to a set of food hygiene regulations which are very rigorous, have been worked out, have been assessed, and they'll have decided whether you should be cooking food there or not. We don't have the same sort of thing for surgical interventions in terms of efficacy, and that means that there's something wrong with that, and that needs to be addressed. You might ask why that is, because it is peculiar, and once you start to think about it, you go, how has it got to this point? And there's no real answer, we don't know, we can speculate. RCTs in surgery are very difficult to do. They're not like pharma. You've not got just a pill, a blue pill and a red pill and off you go. It's skill-based, there's lots of confounders, there's lots of permutations, so it makes it very difficult to do those trials. And if you come from a pharma world where you're used to doing tablet trials, drug trials, once you start in surgery you realise how complicated they can be. There's no question that the profile of the profession doesn't help sometimes. So surgical fraternity can be, not all at all, but underlying it, they're very confident, can be arrogant. And that doesn't help in terms of self-evaluation sometimes. So people who are doing things, I'm okay, I'm doing the right thing, I know I'm doing the right thing, nobody should tell me otherwise. And that does lead to problems with self-assessment as well. So they like to self-assess and say, I'll grade myself, I'll tell people whether I'm doing well or not. And sometimes you do need a third party to do that. And then lastly, I think industry has not helped at all. So that's pilot hip replacements. At one stage, there were something like 320 hip replacements on the market, ranging from £100 to £7,000, all doing the same job. And the iterations of those coming in each time, not necessarily well evaluated, and they were allowed to do that, and you had an explosion of those sorts of things. So there's lots of factors which come in to say, why we haven't really looked in detail at surgery in terms of evaluation. But you might also say, well, it doesn't really matter because nobody's causing any problems. It doesn't, there's no repercussions from that, and that's not true either. So, you can go back to the Royal Navy where the mortality of chopping bits off was 65%. Surely somebody started to look at that and said that's not quite right. There's been other conditions which people have looked at as well. More recently, we've got implants in the arm from a musculoskeletal world. They do a lot of implant work, and this here is an ACR. It's a type of implant, type of hip replacement. It failed catastrophically and it had to be recalled and everybody had to bring it back. It hadn't been put in a single patient before it was put on the market and started to be inserted with it. That cannot be right in any way. The breast implant thing, which has come around quite recently as well, where obviously failing mechanical properties, not properly evaluated, put into patients, and we end up with these problems. So there are some issues, there are some problems, but it's not all bad because we have grasped the nettle now and it's changing. And it's changing through people like this. This guy at the top here is Professor Dion Morton. He's a colorectal surgeon in Birmingham and very eminent in the Royal College. And he has had a vision really to try and sort this out, particularly in the UK. And we have started to lead the world in surgical trials in the UK, which is great news. And they've set up 6 surgical trial centres. We are one of them in Oxford, of which I'm co-director. And the recent one just come on in is York. But we've got a mandate now to start evaluating surgery across the board. Existing surgery, new surgeries, implants, devices, whatever it is, it will go through the Royal College and these centres, not exclusively, other centres can do it as well, but we will start evaluating surgery properly. And these are our dictums. We need to have 2 surgical trials per annum, we've gone way above that. Some new investigators bring new blood in to think about how they do these trials, and we're educating a lot as well. And then we've also got surgical specialty leads, so specialist surgeons in their field, putting their hand up, saying, I'm going to lead this, and any new ideas that we have should come through me, and we'll see whether we need to seed it and look at it in a trial. And there's 15 of those in every discipline. So there's a framework now, and it seems really late in the day, but that's the way it is, but at least we've got a framework to be able to go from. And we will use things like this. It's called the ideal collaboration, and again, this is a framework which we, and the word philosophy is very important up there. It's pre-seed, I've sort of compressed this down. But it's how we might look at trials from now on, how we might look at interventions from now on, starting at a very early stage, first in man, how we go about that, setting up innovation databases, so you can't do trials at this stage. This is anonymous, this is making sure it's fundamentally safe, almost like bench testing surgery. We then have to collect the data in the right way, and so often that's not been done. It's been somebody done in a hospital who's just been throwing data into an Excel spreadsheet, maybe it's got lost. But we have proper ways of collecting data, and that's done rather formally. It may be feasibility that we're looking at, whether it works or not. We then start the bridging work to an RCT, doing pilot work, make sure the measurements that you want to use are the correct ones, and this is a really important one, skill-based learning curve. Can the surgeons who are doing it do it, and how many do they need to do before you consider them competent? And then this is my world, really, the big RCT world, talking about the best practice, full evaluation of efficacy, does it work or not, and comparing it against things. But it doesn't stop there. We need to carry on monitoring, and we go to registries to make sure that there's no devices which are failing, which sometimes is more difficult to pick up than we think. So, that's the need for surgical trials, and I think it's self-explanatory. We don't want to bag them too hard because we've got to be careful. Surgery is very valuable, it's very important. There are holes in there, and there's a balancing act to have between making sure that we start to evaluate it, but not destroying what we've got already. I'm going to go on to comparators now, and how we start to look at things in trials, and sort of pick apart a little bit the methodology that we use in trials. Now, you might think it's just one surgery or one treatment versus another, but it's not as simple as that. Look at the schema here. So surgery, right on the left-hand side, we could have devices or implants, we have non-device procedures. Surgery, which have no devices at all. They can be existing treatments we haven't evaluated yet, it can be new things that are brought in. We can have existing implants, we can have new implants, exactly the same. We can have modified implants. People change things all the time, sometimes with catastrophic results. Somebody will change the shape of a hip replacement just a little bit, to call it a different name, to sell it as a different model, and it causes all sorts of problems. Sometimes not evaluated. That's the bread and butter, but we've now got new areas which we need to evaluate. We have surgical skills. So training people, how we train surgeons, we can do RCTs on that. Is one way of training better than another? That is the existing way of training appropriate. And then more so, we're starting to look at decision making for patients and pathways and management. And again, it's not just an isolated intervention, it's how we approach the whole thing, much more holistic. And again, you can apply RCT methodology to that. So there's a whole raft of things which we can look at. Now, when you start to do that, you go, oh, what should we compare it against? What's the important comparator? We tend to use this thing called PICO, you may have come across it, which is population, intervention, comparator, and outcome. And we're talking about the C there for the PICO. So what do you do the surgery, what do you do the surgery, and what's the population? What is the thing you're interested in? What do you compare against, and how do you measure it with the outcome? One easy way is, relatively easy, is device v device. So a patient needs an operation, and there's two alternatives for it, and both of them are relatively comfortable in a surgeon's hand. So, for instance, we've got total knee replacement here versus total knee replacement 2. It's a standardised, they need a knee replacement, and they're going to get one of the two devices. There's less issues with that. Or, likewise, a procedure which gets to the same point in time, one procedure versus a second procedure, they need that procedure. It's relatively easy to compare. Does it tell you which is best? Yes. Does it tell you the fundamental question whether you need that surgery or not? No, it doesn't, because all it's doing is saying that we assume you need it, we assume these both work. So then you get into the more tricky area of, is surgery beneficial or not? And there we have to start thinking about, this is tumbleweed, so what we're thinking about is having surgery or something against nothing. Surgery, procedure against nothing. That is much more complicated and much more difficult to do. The reason why is because, first of all, ethics, but people are scared of taking away treatment. So it's difficult to go back in time and say, we didn't evaluate this in the first place, we need to do it now. It means taking something away. And the ethics boards are very concerned about that. So we may talk about that a little bit later. In terms of whether you know whether surgery works or not, what's the evidence for it? Let's just do a quick sanity check and make sure that we haven't got that already answered. We did a review in the BMJ, which we were looking at placebo-controlled trials, but in those, there's 53 trials out of placebo. That's not the important piece of information here. Only one of those trials had a no treatment group, so it was all comparing device against device, procedure against procedure. Nobody could say, does the treatment work against nothing at all? Again, it's a bit of a problem for us if we're ruling it out. So there is a black hole, there's a big hole there, and we need to evaluate this in a formal and systematic way. Let's go back to our surgery versus no surgery. Why is it tricky? We've said there's ethical concerns over it because you're taking treatment away. Absolutely right. But there's this issue about placebo. It does not take account of the effects of surgery in terms of the placebo effect. Okay? There's a huge placebo effect undergoing surgery. People will get better even though they're not having it done because they think that they're having something done for them which is making them better. And until you can account for that, having a no treatment group is not your answer. Let's take the patient, for instance. Look at their side for a minute. There's this word equipoise on here. And equipoise means imbalance. So you've got to be, and we'll talk about clinical equipoise later on for the surgeons, but this is for the patient. The patient has to be happy that they're going to have the chance of equally good treatment before you go into this. It's no good going through these trials if you think, I'm in a bad group, I don't want to go into this trial, that group or that particular treatment is better for me, I should have that. But it's never a level playing field with non-operative versus operative. And here we go. If you look on the side here, I've come from a rehabilitation background, and I'm heavily involved in surgery at the moment, but the difference in terms of perception of people is enormous, and it carries an awful lot of weight in terms of how you get better. On this side here, we've got low risk. There's not much risk in terms of conservative care, a few exercises. It's low efficacy, people tend to think of it. Low provider status, lots of glamour. It's a low pedestal that these things sit on, and you have to make that up. It may not be, it may be high efficacy. And the problem is that our communities don't tend to think in that way because it's associated against this. High risk, you've got risk of death, you've got risk of infection. High provider status, high efficacy, it's all badged together, it's a high pedigree. And those things, for me as a trialist, are really difficult because we're starting at different places. It's a bit like this. You've got a little noise line, and it can breed resentful demoralisation. So it's really hard to do a trial when you start off when somebody thinks that the group that they've gone in is the wrong one. So the question we might say, instead of saying against no surgery at all, we've already covered that, might be, we've got the question slightly wrong perhaps, a better question, does surgery, we need to account for this placebo effect, we need to account for all the effects that are sublime, if you like. Does surgery offer greater benefit above that of placebo? And therefore we can control for this effect, we can understand the treatment mechanism, whatever you're doing, it'll separate that out, and we can even, at some point, quantify the amount of placebo effect. And that's valuable for us, and you'll see that later, if you wanted to go as far as offering a placebo intervention as a formal treatment. Some disciplines do that already, and it's not to be shied against. It may have value. So that's an interesting one to think about. We'll come back to it. So, wrong question, maybe. Not necessarily device against device or procedure, not against no treatment all the time, but we need to incorporate placebo into surgery. This caution is needed, and we mustn't shoot ourselves in the foot with this. There are some operations which have obvious efficacy. Hip replacement, trauma cataract, some trauma stuff. You don't want people messing around with placebo trials when you go in and get smashed up in a car accident. You want to have something done to you very quickly which is demonstrated to be effective with or without a clinical trial. So it's things which are more controversial, it's things that perhaps the envelope has been stretched in, and it's certainly some new procedures which are coming on board. We shouldn't look at unimportant questions, and I feel strongly about this. So people will come to me and say, I want to run a trial, and they're great, it's all worked out beautifully, and they're very knowledgeable, but it's on 65 patients that's going to affect in the UK. It's not going to get funded. It's a shame, but it's not going to get funded, it's not going to get looked at. If something is going to save you 30p in clinic, again, you're not going to spend £2 million on a trial to save that amount of money. So you have to have important questions as well. And there's enough of them. There's tons of important questions that we need to look at. And then lastly here, we mustn't be afraid to apply all this investigative stuff to things, but we do need to be sensitive to people's livelihoods. So you can't go breaking down everything here. We've got professional bodies and professions who we have to be very cautious of this, and I'm very mindful of it as well. So if any of you are surgeons in the room here, and we are going to protect you as much as we are going to hopefully give you a raft of evidence to support your practice. It all seems to be positive to me. Okay, let's move on to placebo, which is the actual topic of the talk, and let's go into that in a little bit more detail. Now, placebo is it's a great word, and it's my Latin's no good. I'm afraid, but it's, the Latin is placere, is that right? Any of our Latin scholars here? Placere, placere, du placere? I don't know. None of us, so we're not classic scholars, but that's okay. We're in good company. But it's about deception. The word means deceive. So it's I shall be acceptable, pleasing. So it's to try and please you, and it's a simulated or otherwise medically ineffectual treatment, known to be ineffective for a disease, and it's intended to deceive the recipient. That's a really strong word in medicine, deception. So once you start to talk about deception, people don't like it, but it's the truth. And you've probably seen these guys there. How do surgeons feel about it? Well, we've asked them, and we did a survey, because we didn't know. We had no idea how surgeons, whether they would react and say, no, rubbish, what I do is correct. And it's a huge effect. But we were surprised. They were very sensitive and receptive to the idea that some of their practice, and a large proportion of it, was about placebo. You can see here, over half thought that part of their practice had a placebo component to it. As a surgeon, as somebody who goes and cuts people up and does something very physical, they stood back and said, yeah, some of it is placebo. They were concerned about the deception. 62% raised that as an issue if you were to start selling it as a treatment in some ways. And 48%, when we started to explore whether placebo was the right way to go and talk about placebo, they were concerned because they thought it might break down the patient-surgeon trust. So again, sensitivity and just to be aware of it. But the good thing about that is that the surgeons are on side. They understand it and they're happy to take this on. Right, when you're going to go down this route of surgery, placebo or not, for surgery, it's not straightforward. It's not straightforward because placebo in a drug sense is a tablet which has got the inert thing taken out. It's just an inert drug, and that's it. It's really simple. There are different aspects to placebo and sham surgery. Now, sham surgery is an entirely sham procedure. So that means that the knife, there's no cutting at all, or a tiny amount just to sort of cut the skin and do nothing at all. But there's no therapeutic effect whatsoever, no physiological insult. And there's no surgical value to it. It's a sham operation. So there's some trials being done on that. So the patient goes through the whole procedure of pre-med, anaesthetic, goes there, the team is there, everybody's there, and everybody pretends to do surgery, and then they go out. Which is quite remarkable, and it's very hard to get that through an ethics committee as well. But they exist. A trial on the knee, Moseley trial, which looked at arthroscopy, a washout of the knee. And it was a good trial because it showed that you didn't need to wash out knees in arthritic conditions, and it changed practice considerably. But they're hard to do because the ethics boards don't like them. And also, it's hard to sell it to the patient. What's easier to sell to the patient, a little bit anyway, is a placebo intervention. And what we do with this is where a component of the surgery, which has been identified as the thing that makes the difference, it's the effective component, it's the active part of the drug, if you like, and we call that the critical or crucial surgical element. And once that's identified, you take that away, and all the rest of the surgery is the same. Now, what you're after is saying, if we think my surgery is about this particular thing that I do, if I stop doing that, it shouldn't be effective, should it not? So there's some logic behind it. It's not quite as straightforward as that, as you'll see later. But it's a good way of getting around some of the ethical concerns of the sham surgery. And what you really can do with this is it's a mechanistic argument. You can find out about the mechanism.
When you invite the patients to go into the trial,
yes,
on the right-hand side,
yes,
do you explain the two arms of the trial?
yes. Now we use different
So
language.
you explain,
Now that's so there is some sleight of hand in it to get it done, and you could argue whether that's ethically correct or not. But the world of trials is utilitarian, and we have to. There's a decision to be made all the way along the line whether you want to do this to find out whether it works or not for the greater body, or whether we say no, let's just bin it and sack it because there is some potential, not harm, but not potential non-benefit for that other group. And that's not that it won't happen in the actual intervention, it's just how you couch the language, really. So we are cautious with that. And that is something which needs to be explored in more detail. I think it may get to a point where the community is comfortable with it, but they're not comfortable at the moment. This is early days for this, so they are not comfortable, perhaps, with the word placebo in there. Question about
Hi. Placebo interventions seem to have higher risks to patient than a sham intervention would be,
Yes.
wound infections and all that. So how is that easier to get by an ethics committee than doing absolutely no harm?
Well, they're usually based on, now not all operations lend themselves to this, so you can start thinking about your own procedures if you're medical students or surgeons here. Some will not lend themselves to this. So these are operations which, a lot of them are arthroscopically done, so you can go inside anyway, and sometimes part of the procedure is investigative or minor active procedure through an arthroscope, for instance. And then once you're in there, you may take away some tissue or adjust some tissue or do something like that. It's the taking away of the tissue which is the difference. So there is an argument that there is some therapeutic benefit from the placebo intervention. That's key. So it's not completely inert like this on here. There is just part of it removed.
Can you avoid some of the ethical problems when of not telling a patient about the placebo, when you can, but still retain the efficacy, some of the efficacy, when you consider that some research has shown that you can tell a patient, explain what a placebo is, tell them that they're getting placebo, and you still get a benefit.
Just say that again. So you're saying?
So there's some evidence that you can tell a patient that what they're receiving is a placebo.
Yes.
And you explain what a placebo is.
Yes.
They receive it and they still get a benefit compared to receiving nothing.
Yes, but we don't tell them, so it's blinded. So they don't know that they're getting placebo, so you'd spoil it, you can't.
But if you were to tell them, so there are two possibilities. You're
Yes,
you're
yeah,
either going to
right.
receive one or you're going to
Yeah.
receive a placebo.
Yes.
But even though you tell them the placebo, it's going to be, they might receive a placebo, there still might be an effect.
Yes.
So you're not completely spoiling
Absolutely.
any and all efficacy.
Absolutely right. That's correct. And that's what we base the trials upon, because we don't know. And I'll show you a schema in a second. It'll make more sense to you how we break down the placebo component. So you're absolutely right in that. When we were talking about critical elements of things, it just struck me that, is this peculiar to surgery or whatever? And I thought, no, what else is there? And just as a slight aside, I went and looked, and there was a paper that cropped up, so I was looking to see whether anybody else had talked about critical elements. And the only thing I came up with was a critical element of a joke. And somebody's done a lot of mathematics and things here to work out the critical element of a joke. And they came up with a conclusion. What do you think, just out of thing, what do you think the three critical elements of a joke are? So well, they did all this maths and then they came to a conclusion what the critical element of a joke was. What would you say? Anybody? I was just going to guess. I've got three things.
Deception.
Deception? Kind of.
Timing.
Surprise. Timing. Good. Yeah, timing as well. I'll give you the timing. Contrast, they said, so you have to have contrast in it, and inappropriateness. But anyway, if you want to tell a good joke, just bear that in mind. Okay, so going back to the sham surgery, it's ethically more acceptable because there's no insult. It's ethically less acceptable, so there's no, we're not giving you blacks and whites here. It's not like that. This is a messy world. It's ethically less acceptable because it's got no known value. You're actually doing something, and you're putting somebody at risk with anaesthetic with no known value. It depends on the operation, but it's less easy to keep the patient masked because you're not doing anything. Somebody comes out of theatre, they've got wound pain, they feel that they've had an operation, and if you've just done a little nick, they go, well, I know what group I'm in, of course, I've not had it done, it doesn't feel sore at all. So it's much more difficult to blind and mask from that, and it's much less easy to justify from a consent point of view. So that's where the ethics people come from on that. Whereas the placebo intervention, that's not all rosy either. It's more acceptable because it's undergoing some form of treatment, but it's ethically less acceptable as it's an insult to the body without any active component. So I can't give you answers here and say it's definitely this or that. We're working through this at the moment, and every trial is slightly different, every procedure is slightly different. But it is easier to justify for consent, because more often than not, you're doing something which is established. Now, let's look at schemas and just break this down a little bit. So if we have an overall treatment effect, that's our big slash here, this is the placebo intervention. We've got the general effects of surgery, so not the critical element, but you're just having surgery anyway, so you're going in, causing inflammation, whatever you do, stir it up, cut some tissues on your way to the structure that you're looking at, whatever it is. I put that together with placebo because there's a whole element of placebo. You can't separate those out very easily at all. So the placebo element is something which is like the psych, it can lend itself to neurobiology, you'll see in a second. But this is the thing that we're interested in trying to tease out. What's the effect of the critical surgical element, the physiological difference that happens with these trials, with these interventions, and how large is that? So that's the question. Whenever we set these up, we're trying to find out. And maybe how large is the placebo component as well. As I've said to you, placebo is not straightforward itself. Yes, we think of it as psychological, about expectations, and there's lots of research done on placebos. You can go and look at this yourself. There's somatic focus, a whole reward sort of thing going on, anxiety reduction. There's all sorts of reasons why you might get placebo and can affect it. There's a thing called nocebo. You tell people that you're going to get a negative effect even though you don't do anything, and they become negative with it, which is remarkable. So instead of trying to create a positive effect, you say, do you know what, you're going to have this, if you get this, it's going to be bad. And then you don't give them anything bad, it's as good as the other one, but they feel bad, just because you're told. And then eventually it can worm its way into neurobiological with conditioning and hormones, and changes your immune response, and then you can't separate out what's psych, what's neurobiology. It gets very complicated. That's going to be a difficulty for us as we explore placebo trials more. But that's just to fill you in on the placebo side of it. What are we trying to do with these studies? We are trying to decide how important this critical surgical element is. Now, if it's big, so here's our two study groups. One, the critical surgical element here is really large compared with the other surgical elements. So the placebo, everything else that we've talked about, it is the critical surgical element that makes the difference. So it's a truly worthwhile intervention. Whatever you do when you're in there, take a bit of bone off, cut a tissue, add some tissue, whatever it is, compared with the placebo, it's really important. Conversely, if you've got all this going on here, and the critical surgical element doesn't add a great deal, where we start to question whether it's worthwhile or not. We don't question whether the whole procedure is worthwhile, because it depends on whether you give merit to placebo or not, and we're not at that stage yet. But if you're doing the operation for a particular reason and that doesn't work, I think we have to question it. You're not at this stage you cannot quantify the placebo effect with these two groups. And the reason being is we haven't got a no treatment group. So until we have that, we cannot tease out how much the effect is due to placebo. So going back to design, just to finish this little section off, in terms of design, we said procedure versus procedure, that's pretty good. We said no treatment at all, that's fine, but actually it doesn't tell us the whole story. So we're now looking at a three-way comparison, which will tell us everything. We're looking at the actual procedure, which people think, usually by consensus, that would be the best way to do that. A placebo intervention, which is the same but with the critical surgical element removed, and hopefully a no treatment group as well. And that will tell you everything. So let's use an example of that to highlight it and see how we go through. And this is one study that we're doing in Oxford at the moment, of which myself and a shoulder surgeon and the chief investigators on. So this is a trial which is called CECL, Can Shoulder Arthroscopy Work? And it's a three-group study, 300 patients in it, multi-centre, so it fulfills all our requirements that we want. We're looking at pain, function, cost effectiveness, and what we're doing is to see whether, see this little spur here? So surgeons will go in, they'll see that on an x-ray, somebody's got symptoms of pain, and they will take that piece of bone off. Subacromial decompression it's called, remove the piece of bone. Makes sense, mechanically, logically, got pain in my shoulder, I've got a lump there going through, let's shave it off and take it out. Never been looked at though, so somebody tried that, a few patients were quite good, terrific, let's carry on with it. Why not? No problems. We won't talk too hard about and advertise the ones that don't work. So we've decided to evaluate that. When we set it up, we knew there were going to be ethical issues, so we had a Julian Savalescu, who's quite an eminent ethicist up in Oxford. I'm sure you've got people down here. I've worked down there, some really good people actually. And we had him on side to try and make sure that this went through smoothly, and it worked quite well. But it did show that there were some complex ethical issues, and people weren't happy with the deception. They weren't happy to be involved in this risk. And they were saying, is it ethical for an operation to be undertaken that is known placebo? Would you undergo that? Is it ethical for us to actually say that this is promoting the placebo effect, or we know that it's placebo, that's not different? And that was the argument on one side. But the other argument, which probably won in the end, is it ethical to perform surgery without any proof of effect? And there's your argument that you have to decide yourselves which you want to have. And sometimes it's different if you look at it as a group compared to if you look at it as an individual. And the reason why we say it's one, and I think it is important, is look at this graph here. So this is the operation that we're talking about, that we're evaluating. This is the time from 1998 to 2010. And the incidence of doing this operation, without any evidence whatsoever, has gone exponentially up to 2,000, whatever, 25,000, incredible amount, and will continue to go on up, fueled by all sorts of things, modern medicine, money, all sorts of things. But it shouldn't. That's fine, and we support that if we just show that it works, and then we're happy. So the design for the seesaw study. Here we are. Here's our removal of bone. This is how it's done through an arthroscope. First of all, we have our two groups, which are our two surgical groups. So the placebo intervention and the definitive treatment. This is the bone removed, the active surgery. This is arthroscopy only, just putting in, having a look around, don't take the bone away. It's called placebo arthroscopic subacromial decompression. So we've got our active treatment and we've got our placebo treatment. That's the first comparison. That will tell us the mechanism. That will tell us whether we need to take the bone off or not, really simply. It'll account for the placebo effect because they're both having it. There's no reason to suspect there's any confounders in there. It'll just be taking the bone off. But it doesn't tell us whether the surgery works overall or not, so we need a third group, which is actually no treatment. Now, we can't say nothing to patients. Don't like that. So we call it active monitoring with specialist reassessment. Again, is that slightly fraudulent? I don't know. It's open for debate. We wouldn't recruit to the trial otherwise. So you're constantly balancing these things all the time. But anyway, they come in, they actually don't, there's a natural history, they don't have any surgery at all, but that gives us another control group, which is a no treatment control group. It doesn't really matter which one you compare it to, but I would say we compare it to the active because it's the proper treatment. But that will tell us whether the surgery works or not. And that three-way design will allow you to get at those two things. Yes?
Would you still promise for this nothing group, would you still promise them that once you get the results, that
Yes.
they will get that?
Yes. But it's a very dangerous track to go down, because as soon as you see people with that, they go, well, why are you telling me that? That means that you think the surgery works.
Yeah.
And part of the trials these days is qualitative, to strip that right back down, and this equipoise thing, I'll talk about with the surgeon later, you have to stand in front of the patient and say, I don't know whether this works or not. So you've got an equal chance of being good in any of these groups, otherwise I wouldn't put you in this trial. So we don't say that at first, but it's written somewhere, and if somebody wants to ask that question, you say them with your rep, of course you can have it. But it can queer the picture. Now, one thing that's really interesting about this particular study, and I won't go into this in any detail, I'll just tell you, is that we'll find out those things, the mechanism and whether the surgery works or not, but we're also MRIing them, we're doing a functional MRI, so we'll be able to see if they have a placebo effect, whether it affects your brain or not. So areas will light up in terms of pain. So not only will we have an understanding of the mechanism of taking the bone off, but we'll have a much better understanding of, does placebo effect actually change your lighting up your brain pathways, your pain pathways, and that'll be really, really interesting to look at. Okay, problems and issues. Let's just go into problems and issues with these ethics. Now, I've glossed over it a bit, but you can tell that this critical surgical element is lovely and easy to do in arthroscopy of the shoulder, where there's a piece of bone to take off. You go to a cancer operation, you go to some complex bowel operation. How do you start identifying the critical surgical element of that? So that is going to be problematic. So at the moment we're picking off the easy things. When it comes to the more difficult things, I'm not sure whether placebo designs will be right or not. We'll talk about that soon. Recruitment, ethical issues, surgical support and blinding. I'm going to go through each of those very quickly. So this identifying it, I've already said, not all surgery lends itself to it. And we really only need to look at operations with a clearly defined mechanistic component. If they don't have that, we're not going to do it. It's usually not the core operation. It's normally just an extension of the operation. So you're doing something, somebody's gone into, for instance, this particular operation, people have looked in the shoulder arthroscopically and gone, oh, I think I'll have a little play here, there's a bit of bone, I'll take that off. And that's how the operation is developed. And the other thing is you cannot omit the critical surgical element if it's obviously detrimental to the health. So if you've got a tumour there, you can't say let's leave it in at the moment. It would be foolish. So this critical surgical element still needs some thinking through. Recruitment is a big issue for these trials because the word placebo, people hate it. You say, do you want to go to a trial? Yes, that's great. What am I doing? 2 treatments? No, actually one is a pretend treatment or no treatment at all. So we've got a new way of dealing with this, and there's a group in Bristol particularly good at it, Professor Jenny Donovan. So it's qualitative research, and I've not been a qualitative researcher all my life, I've been very quantitative, but I've really discovered that this is important, and we break down beliefs, in patients, and we break down beliefs in the surgeons who are so fixed in what they think they're doing, and to make them say, you think of a surgeon, how decisive they have to be, decisions all the time, and then we turn around and say, you have to tell this patient that you're about to do an operation that you don't believe works or possibly doesn't work. Why are you doing that? And that's a very difficult position to take them and put them in. And some of them cope with it by saying, I'll do it just for the trial, but I believe it works. But that's okay, because at least we'll get the trial done. It's got some interesting answers. So that's, for patients, it's difficult to grasp, so we're working hard at that. You want to make sure that it's not harmful, and again, this review that we did that, so we looked at these 53 trials, 50% showed that the benefit of surgery was equal to that of placebo. The main headline there is that there was minimal harm. Only a 7% adverse event with placebo, 21% in surgical. So you know if you are putting a placebo arm in there, it is not doing any harm, which is really important for it. Now, something which is not necessarily just applies to placebo trials, but to all surgical trials, is the issue of equipoise of the surgeon. And I've touched on this already by saying the surgeon has to be happy that a patient in front of him, and I'll put them in, or her, put them in either group, and they're comfortable to do so. And that means that they don't have a preference for treatment. And so if we're going to do a trial, where there's a preference, we have to demonstrate that. And this is a set of data from a trial that is called TopCat, comparing to its two devices, two knee replacements, a partial one and a full one. And before we set up, we said, let's just make sure that if a patient did go to some surgeons, they would choose different things to do. So we gave these surgeons, there were different types of surgeons, one was a specialist, one was a knee surgeon, one was an arthroplasty. There were just a variety because we chose that. But we gave them the same set of 150 x-rays and clinical information, or blind, and said, choose what treatment you would do on these patients. Exactly the same pathology, same patient, same qualifications. You could go to two different hospitals, and you would find that if you went to this chap, he would do 80% of his patients this one here. In the other things, they would go half and half. This person here would do 60% of the other type of operation. So the variety was a choice of difference in two treatments, 59% of cases. I don't think that could be. One must be better than the other. I don't know about you, but I can't believe that they're exactly the same, and one might be more appropriate for one patient group. So there is our problem. So what it shows you in terms of equipoise is that it doesn't exist. Some people do prefer to have one particular intervention and offer it to their patients. So when that happens, if the surgeon feels, do you know what, I don't know, I've always wondered about this, I want to do this study because I do both operations, but I've never been, they're in full equipoise, and that's great, you can just randomise by treatment. What sometimes happens is, they have a personal preference, but they know there's no real evidence behind it, and that's a bit more sticky. So we call them in part equipoise, clinical equipoise. They can still randomise because there's enough groundswell, there's enough opinion from their political or their specialist society to allow that to happen. It's a personal preference, but they know that there's a problem with it. The last one is where they have a strong preference, they go, no, I believe in this fully, they're completely out of equipoise. You can't do a trial where you're randomising two individuals. You have to do what's known as an expertise-based trial, and you have pairs of surgeons, one doing the operation that they want to do, the other doing the operation they want to do. The good thing about that is, and they're very rare, they're a rare entity, but you get the best surgery for one against the best surgery of the other. And just this is the mechanism of the top cat, you see, you've got this device, single surgeon. If they get randomised, once the patient's randomised, they do both surgery, it doesn't matter. And you've got confounders taken account of, which is great, but they may be slightly better at one or the other, they may not be an expert at one or the other, but that goes on. In terms of the expertise, we've got these pairs of surgeons, only one does the uni, the other one does the total, and they go to the particular surgeon that does that operation. Downside of this, patients have to swap surgeons, they sometimes like that. Good side of it is you will get the best of each operation being compared against each other. Because even people put their hands up saying brilliant at both, they may not be. Yes, question.
How is that blinded as a patient? You know your surgeon's an expert in unilateral knee replacement.
Yes, patients, that's right, patients aren't blinded with that. You can't blind with that because they know that they've gone to that route. But again, how much do you tell the patient of this? So it's tricky to sort of say we're going to tell you everything. One, it sometimes overloads with information. Two, you get prejudice coming very easily, and you're raising all the questions that we raise all the time with these things, and there's sometimes not an answer to it. But going back to placebo trials, which is about this balance thing, how can the surgeon ever be in equipoise? How can you ever be in equipoise when you know that you're doing something which is placebo? Unless you believe that the surgery that you're doing is ineffectual. And I would say that is morally incorrect. And I don't know many surgeons who do that, to be fair, at all. They're good people, so that's not going to happen. Blinding. Now, how can you blind with a placebo trial or a surgical trial like that? Just what we were talking about. And it's a joke slide, of course, but it's a big operation, James at Bristol. But you can't expect a surgeon to remain unaware of what procedure that they've done. There is occasionally some things which you can do, particularly device-wise, where they're given things and they look the same and it doesn't affect the surgical procedure, but it's very rare. 9.5 times out of 10, the surgeon has to know exactly what they're doing. So the blinding of the interventionalist is not done. It's not the most important thing for me. The most important thing for me is the person taking the measurements. So we don't let the surgeon take the measurements. So afterwards, when we measure them, that person needs to remain blind, and that's the most powerful blinding. The patient is good as well, so they haven't got an opinion. They don't answer any outcome measures with that. The least important for me is the surgeon. Okay, last two or three slides, and we have a little chat, if you feel like it. Interpretation. So, now, you know, you've seen yourself, it's not quite straightforward, it's quite complicated. So when you do these trials, you have to think ahead and decide, what is this going to tell me? And I always try and do this with my trials, but it's sometimes not easy, especially with a three-way group. You can understand the number of permutations that you might get in terms of results. So you have to step through it all before you start, because you have to power it correctly to be able to do that. Let's just take seesaw as an example. So the first question is the surgery effective? And we've got the definitive treatment, the subacromial decompression against the non-surgical control. So if we get a positive result, a superiority in that direction, yep, we say that this decompression works, we're not bothered how, it works, and keep the treatment. If we got a scenario where there was no difference between those two groups, the people who are not having surgery and having the definitive treatment, big problem, we've got a surgery going on, costing a lot of money, which should be discontinued. That will cause all sorts of ructions, but it's the truth. Never been looked at before, we need to do it. Second thing, from a scientific point of view, so this is healthcare stuff, this is public health, should we be paying for these things, should we be doing it, is it the right thing for the patient? This is science stuff, which is equally exciting, but mechanistically, do we need to take the bone off in this operation? The operation might work, we don't really know how. We think it's taking the bone off or not. So the comparison here is between the decompression or the placebo intervention, and if that's better, yes, you need to take the bone off, and we understand the mechanism. If we get this, where there's no difference between those two surgical arms, something else is going on, it's bloody complicated, and we're not going to be able to find out, but there's other reasons for the effect. Probably the least helpful results that we could get. But we shall see, because we've recruited them all, and they're about 6 months into it. So we'll get, whether it works or not, we'll get the relative contribution to the placebo, and we'll get a better understanding of what we should be doing. So let's just say, at the end of this trial, that we find that placebo intervention is just as effective as a standard and routine intervention. And this is about where there's no point in doing a trial unless you're not going to change. I don't do any trials unless it's going to change practice, so there's no point in doing it. If people are not going to listen, or it's not important enough, or it's not going to change practice, why spend government money, why spend your time on it? It's a waste of time. So we'll find this out. Placebo intervention is just as effective. And we remember that 72% was an improvement in the placebo arms. 51% the treatment effect was equal to the surgery, so there's a high percent, there's a likelihood there, it's staring us in the face, that we're going to find that placebo is a good thing to do. Do we administer a placebo surgical treatment? You're a commissioner, it's your money, you're paying for it, it works, it gets people better, but it's artificial. It's a placebo intervention. Have a little think about that. Is it deception? Would that be deception? Deception's, as I said right from the beginning, it's a strong word in medicine, but you could argue that there's a lot of deception in medicine. I do a knee clinic still. I go in and I can almost steer a patient when they come in to whether they want a pathology, which I kind of know about, whether they should have the operation or persuade them against it. It's not deception, but there's some deception going on because you're steering somebody with your knowledge and making out something like this. So medicine is riddled with deception in some way. It's part of the practice, and you're not going to change that. When we start to make it really formal in these trials, it gives people a slightly different taste in their mouth, but it's something that we might just have a little chat about. But it's a cartoon, but it's of course, it was the drugs of that. Our trials show that placebo surgery performs better. Maybe we'll start investing in placebos. Are we going to get a raft of new surgeries, which actually we know they don't do anything, they look pretty good. Lights and bells, coming over, all sorts of things. Okay, let's summarise and just step through and so there's no question that we need to investigate surgery. I think that's clear as the light of day. At the moment, placebo trials in surgery are rare, and I've tried to outline to you why that might be. There's some pressures on it. We are making headway. It's great, but they're difficult things to do, and there's a lot of thought that needs to go behind them. They are going to be mainly minor procedures to start with, because that's the nettle which is less stingy to begin with. It will move into the bigger things eventually, I think. The no-brainers, they're taken out of the equation straight away. You must remember that the definition of placebo is not straightforward. So when somebody throws this up to its placebo trial, just have a look at it in more detail. Is it a true sham trial, which are even rarer, or is it placebo intervention with the critical element removed? They don't do any harm, which is a really useful thing to do. So we feel like we're not doing something detrimental. It's not an investigation whereby we might be threatening people. It's an investigation that needs to be done, but it's not threatening people. There may be some issues around consent and people and informing. I think that needs to be explored a bit more. But in terms of the actual intervention, there's no harm with it. And this no treatment control is something that we definitely need to quantify the placebo effect over time. And then lastly, as I've just said, whatever information is brought to us, we always have to think ahead of the curve, because we're pretty bad in medicine, letting it roll and then suddenly deciding, well, let's have a think about what we're going to do about this. I think we need to sort of think this up front and decide how it's going to affect our practice and our world, because we don't want to chop people's legs off in any way in a metaphorical sense. We need to be very, very cautious of how we go about this, because it's got big implications for people. And I'll picture the Gower for you where I live. Thank you very much. There's a list of people, but these things, as you know yourself, there's a team around you, and the teams are just as important as you are. I'm not going to give a lecture, but there's lots of people who are on the end of this. Thank you. Now, questions?
So we're going to have a brief comment by my colleague David Capino, who's very distinguished philosopher, and I think he wants to talk and not be.
Thank you. That was fascinating. Very clear. So I don't want to talk too much. I just want to raise a couple of things for discussion. And as you can imagine, I'm, as a philosopher, going to focus on the issues of perception. A bit of research methodology at the end. So something about the placebos, and you did raise it at the end of your talk, something I was puzzled about, which is, suppose we do the trials and we discover that the treatment is efficacious, but it's a placebo effect. So what we're going to do, so we're probably going to perform placebo operations on people. But it's not just a matter of I mean, that wouldn't be a matter of just deceiving one doctor-patient interaction. It would have to be a conspiracy on the part of the medical profession. The medical profession all have to know that this operation was only effective because of the placebo effect, and then keep it a secret from all the patients. So I think, given that's what's going to have to happen, you might well think about what's the point of doing the research. And what I'm thinking there is, given the ethical issues that arise. Now, ethical issues arise with placebo in an accentuated form, but they're already there if we're just talking about treatment versus control treatment versus no treatment. And one of the terrific things about David's talk is he was the most honest medical researcher about this that I've ever heard. I mean, he admitted that you are deceiving the patients when you induce them into clinical trials. I mean, as you said, it's very rare to find surgeons who are equipoised. What you hope is you can get the surgeons to pretend to be equipoised for the purposes of conducting the trial. You said that if it's treatment versus no treatment control, you have to hide from the patients that it's just no treatment control. You have to pretend they're getting something. And given equipoise, you have to pretend they're getting something that in your mind is just as good. And I think if we were going to require that the doctors were sincere when they're saying these things, we wouldn't get very many trials at all, certainly not surgical trials. So now, David's view was, well, sure, deceiving the patients, but on the other side is, do we want to go and perform procedures for which we have no evidence they're any good? And a kind of general utilitarian calculation would say, well, let's do the trial, even at the cost of deception. I actually don't think that calculation is good enough. I mean, it depends how you describe it. I mean, when research like this is done on people in prisons or poor people in the southern states of America, and it comes out in huge hands. We're experimenting on people. And I think we might want to think that right? We haven't got people who've been forcibly induced into the research, but still we've got a bunch of people who are being given a treatment or control at random, not fully understanding what's going on. Now, it's very worrying. I actually don't think, even if we were utilitarians or were prepared to outweigh the deception by the benefits, that would be enough to justify the trials. So here's the methodological thing I want to raise. So they put it very nicely. Look, there's some deception of the people in the research, but on the other side, I mean, plenty of people, thousands, millions, getting a procedure which there's no evidence for. But I think there's a false dichotomy here. Either we have trials or we have no evidence. And it's not quite clear why trials are the only way to go here. So David said, I mean, research budget spent on investigating surgery is only 2% of the whole research budget, and I think that's indeed terrible. But then he switched straight to the trials unit, and I think the trials unit means randomized controlled trials. And you get a bunch of patients, and you've got your treatment, your control, and you spin a coin, and some of them get the treatment, some of them get the control at random, but you have to find what's going on, because otherwise why would they go into the trial? And here's an obvious alternative, which is to look at existing patients who've had the procedure, who haven't had the procedure, and see which one to it. Just do a retrospective survey. What's wrong with that? I mean, that would seem a very good way of evaluating surgical procedures. So I'm slightly surprised why there's such an obsession with trials. Okay, we know the story. I mean, it went past very, very fast at the beginning. There's confounders. You can't be sure doing a survey that the treatment isn't being applied to healthy people and they get better anyway. And that's the rationale for doing trials and not retrospective surveys, that you're worried about some confounding influence that's making it look as if the treatment's correlated with recovery when it's not really. It's just been given to people who are going to recover, but some other cause of recovery. But of course trials aren't the only way around that. You can do a survey that takes into account how healthy the people were before they had the survey on the treatment or not. You can compare people of like health who had the treatment and not the treatment. And that's standard survey research. It's standard regression analysis, analysis of variance, and so on. And it's used all the time outside evaluation of treatments. It's used within the medical establishment when you do epidemiology. I mean, it's used to ascertain that smoking causes cancer. I mean, nobody did any randomized trials on smokers anonymous. Get some kids who's some smoking, some. I mean, no. Of course, it seems horrible, but no, we did surveys. And we did have to check very carefully that the people who smoked weren't getting cancer for some other reason. We went through all possible. Of course, we did it fine. And nobody has any doubts about that. And similarly, come to think of it, with all other carcinogens, all other toxic influences in the environment, nobody's doing randomized trials to see if these things are really toxic. You do the epidemiology. You check to see whether there's a correlation between this and bad results, and then you check to see whether it can be explained by any possible confounders. You go through all the possible confounders. And it's not clear to me why the money that's now being put into evaluating surgical procedures isn't going like that, isn't putting a lot of money, because it's not a straightforward business, into ascertaining all the relevant characteristics of the patients who are getting treatment and not getting treatment, and using those data to tell you whether the treatment works or not. So, okay, that's what I was saying. So,
may I respond to a couple of those points? Is that okay?
Sure.
What would you do now? So I'm in agreement with you. As somebody who's tried this and spent such amount of time on this, I'm coming to a point. It's the best we've got at the moment, but it is not going to be the best for the future. There is an awful lot of money spent on answering one question. So these cost £2 million, £1 million each. That cannot be a good investment. I mean, don't get me wrong, the procedures are being done, which cost a lot more. But there has to be a better methodology. It isn't retrospective, because the bias which exists with that gives you bogus results, and we've seen that time and time again where you collect data in the wrong way, it will tell you the wrong thing. So this is the best way of getting an unbiased result, but it's a huge sledgehammer, it's very expensive, it is limited, it hasn't got the flexibility of things which some of the other methodologies have got. And I showed you that ideal framework, and I think that's the way that we will go with this. And we may not ever get to a big trial, but it's clear cut early on, with 40 patients done well, and a relatively cheap evaluation, then that might be better. So I do agree with you with that. And it's a difficult one, because these things evolve, don't they? And at the moment we're on this huge wave, and there's been no evaluation on it. So it's natural that it's going to take what's seen as the gold standard at the moment as the first process. But you watch in time, 20 years, there'll be adaptive designs, there'll be different things, and I hope we won't be doing, particularly the top cap one. We should never be, it'll tell us a good result, but at the end of the day, it's an expensive trial to look at a device with the same performance. So I agree with that. The other thing that does, and you could tell that it grated with me all the way through, was this utilitarian and individual thing which goes on. We have that now, and it's ever so difficult to deal with, because you sit there designing these trials in an institution, surrounded by everybody thinking the same way, and you methodologists, statisticians, and you tick the boxes and you get it all right, and you put funding bodies, and there's the same people sitting there, and you're all looking at it the same way, and everything like that. When you come as a patient to these things, you look at it in completely different eyes. And as a patient, you go, I want to know everything about it. I want to know, I don't want you to tell me maybe, or you're giving me a little sleight of hand. And I don't think we've reconciled that yet. And I'm not sure whether we will. I don't know how we will. So any questions at all before we for David or myself?
You mentioned when you talk about medical devices that have little evidence, surgical devices specifically, and implants and things that didn't have much evidence before they started being used, what they're used to in widespread.
Yes.
What now are the regulations, if any, that manufacturers of these have to, do they have to produce any evidence to prove that they work or that they're safe before they use them? And if there isn't, or what do you suggest can be done, and is that easier to do trials on new devices than it is on existing surgery?
So there's lots of questions in
there,
which is great. First of all, no, the regulations of the government is still particularly poor. So it's all about catastrophic failure and safety. So it's joint registries or operation registries which will show you when things go horribly wrong. And that's all. And sometimes they get missed until it's very late. So the upfront, a priori evaluation of these things doesn't happen. It's all out of the horses as well, which is a problem. They're trying to bring that back. I would love to see a world where nothing is brought into place until it's got a safety check, reg safety check, human safety check, and some efficacy as well. So, and that for me is where I come from with the trials. It would be nice to be able to say, you have to have something which shows it works before you can go and sell this thing. But we've just talked about placebo, and if it's a placebo thing that works in something, the devices are very different. I mean, hip replacement, no brainer, let's not go there. But some things which have placebo components, you're almost back to the wizard of the room. You almost go back and say it's okay to do that. Why have we spent all this time investing and thinking about it? And at the end of the day, medicine is much more art than science, or we don't really understand the science side of it sufficiently to be able to unpick it and say what's good or bad. So the governance is still poor, and it is improving a little bit. You can design a new implant and you can have it for a year, and it's called ODEP rating. 1 year is sufficient, 3 years better, 5 years is better still, but it doesn't stop you from putting it in the market. So people having things put in still, which have not been shown to be efficacious, they're probably safe because they're based on a standard design, but it doesn't always happen.
So I was curious when you said that the retrospective data will always tell you what you wanted to tell you, and I can see there are problems, but this is a live issue, isn't it? Because we do have retrospective data being used to evaluate our procedures as surgeons nowadays.
Yes.
And I appreciate how terribly problematic that is, given the size of the samples we're using and so on. So But why retrospective data no good for evaluating procedures?
Well, it will so the things that I'm familiar with are the registries particularly. So there are requirements now for certain operations where anybody who has an operation has to be logged and sent to a national registry. Each country has their own. Let's use implants or knee replacements, hip replacements as an example. That will pick up, so all that data is going in, people are looking at it all the time. It will pick up when something goes wrong. So there will be a revision. And the trouble is the measures for failure are imprecise and very clumsy. The only way that it will pick up a problem is if people have another operation. And that means it's catastrophically failed. So it's failed at a particular time. This is a device. So you go, how many revision surgeries have you got for this particular device? It's 50% compared with the expect 5. Something majorly wrong with it. There may be other devices that don't get revised, which have also failed.
But your sort of existing retrospective data,
Yes.
it's not good data. The categories aren't precise enough. You haven't got enough fine tuning. You
Yes.
aren't taking enough account of different
Yes.
conditions of the patient.
Correct.
But so that's just. I mean, current retrospective data. My suggestion was why aren't you putting all your weight behind making sure that in the future we gather good data, which will then avoid those problems.
So we are. And you saw at the end of that ideal thing. So one, I emphasised that in terms of monitoring and post-market surveillance now has to be much better than what it is. So and formally collected, appropriately collected data in that way will be valuable. As long as you understand, so trials are not the be-all and end-all for me. If you understand what your foibles are, same with anybody, any issue in life, if you understand what they are, you can deal with them. And I think it's what we've done is ignore those in the past. So if you understand what the problems are, some of these other designs and these sets of data are very, very valuable.
Just about this retrospective study issue, how would you be able to control for the placebo effect with the retrospective study?
I'm pretty sure that that's what's happening, but you might get lucky and find a few surgeons who kind of bailed out halfway through the operation. You find out, and you include that in your data set.
But it's a special kind of confounder because all of the retrospective data would be people who had chosen, who knew what they had.
I mean, it's unlikely that naturally occurring data will include many cases where the surgeon started the procedure and left out the crucial bit. But there might be some, you might get some by luck, but I wasn't especially pushing to solve that. Placebo's other problem, even if you find out there's a placebo effect, what are you going to do? I mean, that's better not know if you ask me.
Well, that's what we touched on, we're not there. But you raised a really important point, which I've deviated from very easily, and it's understanding what's in the surgeon's mind. So we don't know, we have no tools or measurement device to know how in equipoise they are or what they really think. And there's going to be a spectrum of individuals, of people going, I don't care, I know I'm doing the right thing, to I'm really worried about this because I don't really know what I'm doing. There's going to be people with their head in the sand who go, no, I don't know what it is. There's going to be people who go, I think it's okay, but I'm not sure, I'll carry on because I was taught it somewhere. There's people who go, I'm evidence-based, but if there's no evidence, I'm not doing it. And you don't know, and there's shades of grey within each of those heads like that. And each clinician or surgeon in front of you is one of those things. So they're not homogeneous, and that's really tricky to deal with when you are trying to tell the surgeons. We go to these places and say, you need to say this to the patient, this is our pattern, because it has to be uniform. And depending on, they go, you can tell straight away. They'll go, I can't say that, that's not for me, that's not the way out. Or they make their own up, or they'll say it in a way which you clearly see that they're not convinced of what they're telling the patient. And that affects them. So the patients will read you, and it's a slightly different issue, the qualitative side of it. So if you're nuanced and your voice and the slightest change, you can have this, which is letting you think, or the other, which straight away, nobody will go in it. So we spend a lot of time, not just coaching, it's not supposed to be a facade, it is actually breaking down people's beliefs. And we say, just think about it. I want to know where you stand on this, really. You need to think inside your own brain and decide. Are you practicing? Where's your belief system coming from? And they all get a bit panicky. This is not what I was taught in medicine. I was taught just this. But it's a good thing to do.
Sorry to keep talking.
No, it's good.
Should Surely it's easier, therefore, to do placebo-controlled surgical trials on new procedures, new devices, because where people have yet to develop their opinions on it.
Absolutely.
And is that an easier way to get started on the placebo-controlled
Yes,
trial?
it is, and these are relatively new procedures in the grand scheme of things. So the arthroscopic stuff tend to be in the overall relatively new. So you're correct in that. The only trouble is that new procedures don't come along very often. So there will be, and the ones that do come along are usually quite esoteric and rare, transplant stuff, weird stuff. So they're not going to lend themselves to this. The bread and butter, sort of standard operations, removing tissue, cholecystectomies, appendectomies, joint implants, cataract, all those sorts of things. There's a whole raft of them which work, and it'd be foolish to say that they don't work. So that's not what we start evaluating. What has happened in surgical practice is that people take a position and stretch it and go in these directions, and we just don't want that to happen without it being evaluated. The last thing I want to do, and this is a really important point, is stifle innovation. So we would cause as much harm by stifling innovation with our way. And I'm worried about this with the trials. This comes back to your point, David, about these big trials. They're not the only way. If we have to have a big trial for everything we do, we won't progress very quick at all. And again, that's something to reconcile.
Yeah. So the examples that you have been talking about have been these sort of two-arm trials. So are these sorts of trials ever multi-arm?
Yes.
Is there a difference in patients, but also the practitioners' willingness to participate in multi-arm trials?
Okay, good question. The more trials you have, the more complicated it becomes. Full stop. So that puts brakes on certain things. 4 or 5 arms. People are, what am I doing? I don't really want to get into this. It all comes back to your question. It depends what you want to answer. If there's things which are summative parts of the treatment, so A plus B plus C, then you can do those sorts of trials. With placebo, we've stayed away from it at the moment. That's as elaborate and as sophisticated as we want to go to, because you can see we're still testing the water and treading gently. It may get to that, I don't know. The danger of it is that you have to power the study. That means getting the sample size sufficient to be able to answer every question which you're trying to test. And that can mean huge, big trials. So when we look at groups, we need to really consider the question that we're asking. And if it's a simple question, stick with a simple question. If it's a complex question, fine. But remember, you're going to need many more people with it. Good question.
I've got a question about the equipoise.
Yes, that's it.
So I'm thinking about it from the patient's point of view. And so you want me to come into the trial. You have to say to me that, as far as we can tell, all these different arms are equally good for what you've got. And you're saying, well, a lot of doctors kind of might fit roughly under that, because they might have some worry about the treatment they normally give and so on. But I don't care about that. I mean, if I'm a patient, and that's said to me, I know, what it's supposed to be, I can operationalize it very easily.
Yes.
Which is, you're the doctor, imagine that it's your wife or child here, your husband here, and would you really be happy to spin a coin to decide which treatment your child gets? And to the extent that the doctors aren't in that situation, which I take it you would agree they mostly aren't, then there's still something to say to them.
There is, but you turn it on its head and you say, I'm about to give you a very invasive procedure which could threaten your life with infection, even death, or whatever, and we have no evidence that it actually works.
I don't care. I'm the patient.
But you wouldn't worry about that.
There's an equivocation here between where the doctors, we don't know if this works better than that, which is the situation you're in, and which makes you want to do the research. There's an equivocation between that, and we are absolutely equipoised. We would be happy to spin a coin for our own child, which is what needs to be the case for you to say what you say to get me to go into the trial. And so there is an element of deception in the gap between the two. And you often, I'm sure, you'd really like to know. I'm not denying it would be for the general good of the human race to know. Absolutely.
Yes.
But I'm worried about your deceiving people
Yeah.
in order to...
I'm worried about me deceiving people as well. And I'll give you a personal example of that, where all my wealth of knowledge on this on one side, I've got a friend whose son got leukemia, and they invited him into a trial. And there was a drug, and there was a new drug, which is an additive drug, the components are the same, and they didn't know whether this new drug worked or not, but it was a summative thing. And I had to recommend that they didn't go in the trial, that they would take the new treatment because it was summative. And if it was my child, I'd rather them go into that, because they had more chance, probably, even though that was unproven, of having success with it. Now that is problematic as a concept, which is I think what you're getting at. So from a philosophical point of view, I'd love you to come up with some solutions for us, because I'm going to do that. Questions like that.
So after the findings of your research,
Yes.
you've discovered that there is a placebo effect.
Yes.
And after your findings come to light,
Yes.
how do you see that it will impact on surgery's position in a lot of hospitals? Because it seems that it's no longer the privilege of institutions to conduct this kind of placebo.
Yes.
Surgeries having placebo effect.
Yes.
And do you still think that the hospitals are more than entitled to charge even the same price for even something that they know that
Yes.
is nothing at all?
Well, yeah, really interesting. So the first thing that happened is that a whole group of people would ignore it, which is what tends to happen with medical evidence, which breaks your heart, but it will happen. Now, because the authority and the governance for how things filter down and get changed is complicated, it won't happen immediately, but in the first place people say, I try and change me, I think this is right for the patient, so I'm going to do it. And therefore, you wonder whether you're wasting your time. But on a larger scale, we are now actively, and I don't like this word, but it's happening, we are actively rationing our healthcare. And we have to be cautious about what we spend our money on, because we haven't got unlimited pot. So you might as well spend it on the effect thing. The commissioners, the people who are responsible for choosing those things, be it the CCGs, be it whatever they change the name to now, the bodies which choose which treatments we should pay for within a publicly funded health system, they need to base their judgment on something, and we want to be able to give them something to do that. That's all that this is about. I'm not saying it's the all and end all. If you make a decision against it and it's rational and it's justified, I'm quite comfortable. But our game is to be able to provide you some information, some evidence, which will help you with those decisions. And I wouldn't go any further than that.
I find it fascinating, the whole sort of concept of what you're going to do when you've got a result.
Yes.
Because I can just see
Right.
you're going to come out, the placebo effect. So are you going to do these placebo surgeries because it's better than or just as good as anything else? And then what are you going to do when the Daily Mail gets hold of it? I mean, seriously.
It has got to be managed really well. And there are people around me, and I'm not one of these at all, but I've got people around me who are pushing barrows in a direction which I'm not comfortable with, actually. There's no hobby horses here at all. We're trying to be genuine. It's easy to be sensationalist about it. It's easy to use it for your own means and go around sort of slashing and burning. And that's the last thing I want to happen, really. So you're absolutely right, it does have to be managed. But at the same time, it will be the truth. And if it is the truth, I do all these trials with absolutely the best intention, and we can't hide from the truth a little bit. So it's about managing how we would deliver the truth.
I'm kind of curious. I'm thinking about the bone spur
Yes.
shoulder. So you explained how you dressed up the no treatment.
Mm.
Maybe I wasn't concentrating. How did you dress up the placebo?
It doesn't need to be. It's surgery. People love it. So that's the whole point. The surgical art, and it's a phenomenon. It's a really unusual thing, because half the time I spend in clinic trying to persuade people not to have surgery. They come like, wow, I'm ready for surgery. Let's go for it. And you go, why, where have you got to this position from? And the drivers for it are weird. You know,
Sorry, but let me just get clear. You say that you might get managed attention.
yes,
That's no treatment.
yes,
And then we're going to do 2 kinds of
surgery,
and you leave it at that.
yes.
And you don't tell them the second surgery you're going to have a general anaesthetic.
Yes,
The
we
shoulder
tell
come
them, no.
open, and you're not going to do.
No, they're told that they may have a surgical procedure, which is an arthroscopy, but they may not have the bone removed because we don't know whether you need the bone removed or not. And people are happy once it's been explained to them like that. And we have recruited 334 patients to do that without.
So, and you put that in such a way that
Yes.
they might understand you as saying, we won't know when we've opened up your shoulder whether
Yes.
you're one of the people who needs their bone removed.
Yes, exactly right. And we haven't done it in a way of coercion, or we haven't done it independently with our own sort of surgical pals. We've been to Bristol to.
I'm afraid I feel the Daily Mail ought to know now. And I really do.
Well, let's give the alternative. So the alternative is that we stop this and we say this is wrong. This is wrong. We shouldn't do this anymore. We can go back to looking at sort of large cohort retrospective data where there's so much bias in there. You end up with people who have different sorts of motivations.
Well, I'm afraid in that particular case, as we've seen, I mean, we'll be better off not knowing that there's a placebo effect here. Because if you do find out there's a placebo effect, then you have another problem. Are you really going to keep the secret from everybody? So you're going to lose an effective procedure. I mean, if it really is an effective procedure relative to no treatment, we're better off not knowing. I mean, it's really not something you should be looking at.
How can you say that, Professor? By saying that we should really be better off not knowing. That's a very strong statement.
Well, from the point of view of effective treatment for patients, I mean, the procedure versus no treatment, let's suppose it turns out to be really good, right?
Yes.
And let's suppose that the placebo, as you said, is tied to the high status excitement of having an operation.
Yes.
Well, then what does it matter whether the bone removed?
No, it doesn't matter, but at least we know that. So if that happens, then we can maybe, and I didn't touch it any further on this, provide that intervention cheaper. So whatever the effect is, it's your drug effect, it's whatever it is that you get your high, but we can give you your high in a different way, which is cheaper.
But
We
that
can
would
direct.
be benefit, right?
Well, there will be benefit.
No, that would be the only benefit, that it would be cheaper.
Well, you get the benefit, the clinical benefit, because we've shown that happens, even though it's placebo, but there'll also be the benefit in as much that we can deliver it cheaper, perhaps.
But, I mean, compared to not knowing that it's no better than placebo. So if you'd be spending more money, but the
Yeah,
benefit is.
yeah,
We know it's better than not doing a placebo operation,
yes.
right? So there is a benefit to doing placebo operation, and there is worth doing.
I think so. And that will be another argument. People will sit down and go, how much are we willing to spend on this as a placebo operation? Does it really matter? So, let's go full circle, and you're right. You go, but we need to know that. We need to find out first before we can let it go. So if we find out 3 or 4 of these are placebo, and as an institution, whatever you are, you're happy to pay for it, then we will let people do that. But then at least you're doing it on knowledge and not black boxes or void spaces.
But imagine that the word gets out, and then the treatment will be no good.
I don't
And then you lose the effective treatment.
Well,
I mean, I'm serious.
so that's when you have to educate the public a little bit. And I think we've got responsibilities. It owes us to now, people, not only should they be aware that they might go in these trials, they should be aware that they're going on, they should be aware that this research is happening, they should be aware of how decisions are made. And people would be terrified to know, well, they'd be terrified to know that the fact that a lot of surgical procedures aren't evaluated properly in the first place. The whole stuff that I've talked about, there'll be a lot of nervousness about, and the results of them that we get as well, Daily Mail aside, that kind of stuff, it is sensational stuff, and it's going to scare people.
I don't come from a science background, so this might be a medical ethicist.
Oh, fantastic. You should spoke earlier.
I'm just, the trial with the shoulder thing.
Yes.
I just want to get it clear.
Yeah.
Do you think that if you had told those people who were getting surgery to have a look and then take it out, just have a look but not do anything,
It's
if
very,
they had known what was going on, they would have said no to your trial.
no.
Really?
I think there's probably 3 groups of people who are in that, and it's hard, I'm not saying every, we've seen a few of them, but until you're there with the recruitment point contact, you don't know. There will be people who, and I'm sorry to have to say this, are oblivious to anything that you say to them. And they'll go, yes, yes, whatever. And you can tell them 3 times over it's supposed to be informed consent, and they really just do not care or do not, whether they don't care deliberately or whether they haven't cognited the information, whatever it is, it's just passing them by. There's another group who actually are on the other side of the coin, and they are completely informed and say, yes, I understand exactly what's happening. They're rare, and I'm happy to go into this because it's been explained properly, and I know that. And then there's a sort of grey patch as well, that people have pieces of either side, depending on which mood that you catch them in. And you can't legislate for it, so we can't make them all. I mean, it'd be a lovely world that we educated everyone. They went to trial school or recruitment trial school, and they all came out with all the knowledge, and that doesn't work like that. You've got 5 minutes in the clinic, and somebody comes in and say, well, we're trying to evaluate this. This is the study. Would you be interested in it? Sharon down the road there will tell you about it in more detail if you're interested, because I have to see 34 patients this morning in the next 4 hours. So it's, the pressure's on them. There are so many ethical, philosophical issues with this thing, all probing at it, and you'd be a fool to make it simple, you'd be a fool to dismiss anything at all, you'd be a fool to say that this is how it should be done completely. It's a lovely, rich area to explore, and I think you'll see lots of articles and things like that in the future. But do you think, as an ethicist, do you think we're doing something wrong? Let me ask you that.
Student.
It doesn't matter. I'm interested, do you think, from what we've seen? I mean,
Yeah, honestly, it strikes me as a problem for people making choices. Just particularly, I think, because you've got the surgery field, it strikes me as a problem because, like, surgery is the high risk level. Is that obviously when you recruit people and you have this grey patch that you talked about, but you're not. The worst thing that you are doing is not treating them, and we already know in science, okay, there's probably going to be a placebo effect, so they're probably going to get something.
Yeah.
In this one you have that, but then you also have, like, you might die under anaesthetic, right? Which seems like quite a big harm to weigh against, and the fact that you've said that there are oblivious people, I mean, that's, a little scary.
It's a scary world. And the problem is the clinician know all of this, so the surgeon and their particular characteristics and the population relationship with surgery and surgeons is not helpful at all. So you'd be amazed if you went to assessment clinics, people just go, yes, complete trust. Cut me open, do whatever you want. Complete trust with it. The belief is that it will be sorted out. You know exactly what you're doing, crack on. And I just come from a position where I realise that that's not the case. And thankfully, most of it is okay, but there's some gaps that we just need to make up. The drug world is really different. The drug world is the government will help 10, 15 years before you can even bring anything to market. It's so well disciplined. And the efficacy, the things that you're looking at, are tiny little increments. There's only about 40 drugs that bloody work. It's ridiculous. And then, so you bring something on the market, you spend 20 million quid developing it, and it's 1.5% more effective than the last drug that you did. And it's taken 15 years to get there. And yet, surgery, my colleague could turn up and go, do you know what? I'm going to cut this out. See what happens? And that is just light years away from the other side. That ethically, to me, is a concern as much as all the other sort of slightly sort of bitty, very politically correct things. I think the huge things that stand you in the face is that we're doing things or allowing people to do things which have no backing or evidence for.
But do you think that perhaps you're trying to apply the rigours of one field into another field?
Yes, that's
and perhaps getting slightly blocked, because you're saying you're hammering home this evidence and I want efficacy, but at the same time you kind of, by David, you've been, you've been defending, well, maybe the placebo will turn out to be, efficacious, and maybe then we'll have to have this mass conspiracy on behalf of the NHS. And I mean, if the NHS makes it. But that to me just doesn't seem like it's actually going to be a thing ever. Like, it doesn't seem like you'll ever actually get anyone to fund magic operations. So I don't know how much the focus is on efficacy.
Now, I'll correct you on that. I think you will. You will get.
Really?
Yes, because if the burden of the health, so whatever it is, and the burden of that is substantial, so looking after somebody, and you can improve their healthcare where you don't have to look after them so much and pay for their standard healthcare by an intervention which you have no idea how it works, but it just does work, you will fund it.
But then you're increasing the whole health system's reliance on poorly informed consent, which is really
It's
like
not
a very
informed
structural. No, you said they were oblivious. That's not informed consent. That's ticking a box.
Yeah.
But it's not informed consent. So then you're creating, like, that's a bigger structural thing that you're introducing to the health system, is to say consent, like, no.
Yes.
Which is a little scary.
I agree. We've strayed away from trials and placebo, and we're talking
Yeah.
about now about treatment in general, which is, that's fine, but that's a much bigger nut to crack than what we should be paying for and how we should approach it as a population. I mean, it's coming to, the thing is, we had time plenty and all these things, they proliferated and people got away with it, but it didn't matter, it didn't really matter. And now it does matter, because you've got a 2-year waiting list, there is just not the money to do that anymore. And we're asking people to decide what they want to pay for, in terms of health.
One last question.
Yeah.
I don't think it is a mass conspiracy that you described, right? So let's say it does turn up, a placebo intervention that doesn't take out the bone spur, but just has a look and by magic you get better, right? We have the evidence then that it works. We don't know why it works.
No.
Yeah. Do we have to know why it works to know that it works?
I don't think it's a conspiracy because of that. I think just in terms of the fact that you have to maintain blurriness on behalf of the person, like, as in the person has to not know what's going on
As
for
part
it
of
to
the trial
work.
or after the
As
trial?
part of it being implemented. I mean, is that...
Well, because the surgeon doesn't know either. But
No,
know it
nobody
works.
knows. It's, well, we just know there's a component in there which makes it.
They know as much as the surgeon.
People get better or they feel better, and if you can provide that effect by a much cheaper process. So I'll just give you an example. Let's use our shoulder one. So the placebo is just as good, but you know that you have to pretend to do an operation to do it. You could get very slick at pretending to do an operation, and it would be much cheaper. And you could say, instead of costing £3,000, you can do it for £650 as a pretend operation. Now, as a commissioner, I go, ooh, that's quite good. So let's show that it works, that's fine, we've done that, so people do get better, their pain goes. Which one are you going to choose? The one that is going to cost £3,000 or the one that's going to cost £650? What you can't do is say we're not going to give anything at all, because you can only do that if we show that the placebo has no effect. And you have to take burn, which might be the case, that's the point of the trial. I would be doing it if we knew already.
So I think you
Well, let's all thank the speaker and the comments.